I would first of all like to thank the ASGE for this opportunity to present our work on Upoem for Zenker'S Diverticulum using a standardized protocol. Our disclosures. Flexible endoscopic septomyotomy for the treatment of Zenker'S Diverticulum may be complicated by mediastinal and subcutaneous emphysema. Upoem is a novel third space endoscopic technique to perform septomyotomy. Underwater Upoem replaces gas insufflation with saline submersion. Upoem has potential advantages. With the gas off, there is a reduced risk of gas-induced adverse events. There are optical benefits of water, the magnification, less light artifact, no fogging, no smoke, and a gravity-free 3D floating effect. This provides the opportunity for enhanced precision of dissection and hemostasis. There is also a heat sink effect that reduces the risk of thermal injury to deeper or adjacent tissue. The aim of this study was to evaluate the clinical outcomes of Upoem for Zenker'S Diverticulum using a standardized protocol. Equipment: a high-definition gastroscope with near-focus capability. Transparent caps, both a small and a standard caliber. Irrigation pump, hooked up to the endoscope auxiliary channel. See that here. Sterile water is infused without additive. A foot pedal is used to control infusion at 25 cc's per minute. Hybrid knife, both the I and the T type. Injection of saline mixed with indigo carmine. Dissection settings are endocut I, effect 2, duration 3. Hemostasis settings, force coag, effect 3, 100 watts. And we used short stem clips for the mucosal closure. All patients underwent general anesthesia with endotracheal intubation. Left lateral position. When the gas was on, we used low flow CO2 to perform the mucosal bleb and the incision, as well as clip closure. When we went inside the submucosal space, we turned the gas off and we infused saline. We used a small caliber cap for submucosal dissection and exchanged this for the standard cap for clip closure. Broad spectrum antibiotics for 5 days. We performed this as an outpatient procedure. This video shows the procedure. The gas is on. This is the hybrid knife, and we use it to inject and raise the submucosa to create that bleb and to immediately then incise the mucosa. So here you can see the incision, which is 1 to 2 centimeters in length. And then we enter into the submucosal space. We turn off the gas, and we first dissect on the diverticular side of the septum. Now we're on the esophageal side of the septum. We are infusing water to distend the submucosal space with the infusion pump, and we're injecting through the hybrid knife and applying current to dissect the submucosal fibers. Here you can see nicely illustrated how we're able to target these blood vessels that are suspended in the submucosa. So this is an advantage of the underwater technique, that we can identify and isolate these vessels and prophylactically treat them. This is the septomyotomy, and we're doing this layer by layer. The water's buoyancy effect allows us to separate the fiber layers of the cricopharyngeal muscle. We resect to the base of the diverticulum, and this is generally where the esophageal wall starts. So here we are at the base, and now we close the opening starting on the proximal side with short stem clips, and then we zip up the incision by placing sequential clips within a few millimeters of each other for a secure closure. As we go more distal, the gap between the margins decreases and facilitates the closure. So now our final clip. Results in 31 patients, mostly elderly. One patient had undergone surgery from an open operation. 4 patients had had endoscopic dilations and septal myotomy performed by ENT surgery in 4 patients. Mean Eckhart score of 9. Technical success, 100%. Mean procedure time, 40 minutes. One patient had a contained leak after the procedure and had clips reapplied with secure closure. Mean follow-up, 41 weeks. Patients requiring repeat intervention, just 1. This was a savory dilation, a single session with complete resolution of dysphagia. And the Eckhart score in all patients at final follow-up was 0. Limitations of this study: it's retrospective, single center, single operator with limited follow-up. In conclusion, Upoem for Zenker'S Diverticulum using a standardized protocol resulted in high clinical success rates with no serious adverse effects. Further studies are warranted. Thank you.